not that
I
bad.
mean, you don't have to tow it anywhere, so that's nice. You just go meet up with it and then take it wherever you're gonna
Right.
go. So
Right.
that's nice.
We'll give it about another minute.
Yeah, not having the prep work involved or in the cleanup.
That's everything,
That's yeah.
man.
Yeah,
On
you spend more time on
a
the prep and the
friend's
cleanup than
boat
you
that we
do.
went out on, we had to spray it down afterwards. We had to deck
Yeah,
brushes.
yeah. You
Takes at
spent more
least
time cleaning it than you did on it.
an hour of yeah. Takes it.
And that's what's he got, like a 15-footer, 20-footer?
He's got a 22. Shoot, what's the
I
can't
wouldn't
think of the name.
know.
It's a center console.
Okay.
Uh, Key West. It's Key West.
Yeah, I wouldn't know.
All right. Well, we'll go ahead and get it
Yeah.
started. I'm gonna go ahead and share screen. And for those of you that are just joining in, we do a weekly. So again, we host these webinars every Tuesday, 1:35 to 1:55 p.m. Eastern Standard. And we do a little trivia question just to see where everybody's heads are at. Usually they're on last week's presentation topic, which last week we talked about MIPS and safer guides. So I'm gonna go ahead and share screen with today's trivia question. Jose, let me know if you can see okay.
Yep.
Awesome. So went light on this question today, but let's see let's see where everybody else is. The question today is, what does MIPS stand for in the context of healthcare compliance? And the choices are A, medical incentive performance system, B, merit-based incentive payment system, C, medical insurance provision system, and D, merit-based insurance performance scheme.
You don't have pain in the rear.
So go ahead and just chat or go ahead and put your answers in chat. We'll give it a second, let everybody provide their answers and go from there. Don't be shy.
Yeah, you don't have pain in the rear though, so it can't be.
Yeah. All right, we got
Wow.
Jennifer with B. Don't be shy. Put your answers in chat. We'll give it another 30 seconds.
Yeah.
Man, should have wore a hat.
It's just really bad because you got your beard and then the top of your
It
head is so
looks
dark,
brutal. Like it
It's
doesn't. I feel like it looks worse on camera than in person.
probably because yeah, the cameras do a little bit of
Oh
cleanup
no,
on your face and everything.
it's doing a
So
little too much cleanup. It looks like it looks like I boiled my face. For those of you that just joined in, yeah, I got a little sunburn last weekend, so go easy on me. All right, so we got a couple answers in here. We'll go ahead and roll with that. So again, the question was, what does MIP stand for in the context of healthcare compliance? Was it A, medical incentive performance system, B, merit-based incentive payment system, C, medical insurance provision system, or D, merit-based insurance performance scheme? Answer is B, merit-based incentive payment system. So Jennifer and Bindell, appreciate you participating. And you guys got it right. So we'll go ahead and get started on today's presentation. Jose, just want to double check one more time that you can see okay on the screen.
yep.
Awesome. So everyone, again, thrilled to have you on today's webinar. I see some new faces in here. And just to give you a little bit of background, we've been hosting these webinars since September of last year. And really the goal behind these, we want to keep these topics compliance related for the most part. We've done a couple spin-offs, a couple interviews outside of that, but again, company that I represent is Epi Compliance. We specialize in healthcare compliance, specifically with HIPAA, OSHA, and Medicare regulations. And our goal is simple. We want to protect our customers in the event of any inspection was to occur, especially on the OSHA, HIPAA, CMS side of things. And again, our goal is to provide compliance solutions to students, healthcare providers, healthcare compliance officers, and business associates. So, again, today's topic, we're going to be talking about enhancing healthcare efficiency is the heading, and we're going to be talking about EHR, structured EHR documentation. I am joined by my co-host today, Mr. Jose Delgado. He's
How
a
you doing,
healthcare
everybody?
he's a healthcare consultant with over 17 years of experience, and he also currently owns a mental telehealth clinic as well. Jose, did you have anything to add?
Yeah, no, this is something I deal with on a day-to-day basis, especially as I bring on new providers or we deal with the ever-changing need to make sure certain documentation is there so it can support the clinical decision making, and then just as equally important, so we can get reimbursed for said clinical decision making. Because if we can't get paid for it, then we're not going to be doing those services much longer. It's kind of the way that things go. So
No, absolutely. So, without further ado, we'll go ahead and just dive right into it, Jose. And
yeah, so I mean, when we got to look back at what was the what was the selling point behind EHRs 20 years ago, when even before President Obama really pushed it with the PPACA meaningful use, right? The idea was that the insurance companies wanted to understand the data and measure different ways in which providers were using the codes, and make sure that people were getting the quality of care that they deserved. In reality, they were just tracking, and they have been just tracking so they can audit random. Really, it's more outlying practices. So, what we want to do though is we want to make sure that we're using the same methodology they're using to, for lack of a better term, entrap us. We want to use it in a way to prevent that and also make sure that we're maximizing our workflow. When we look at structured, what is a structured data? We're looking at basically data that in the beginning with Internet 1.0 and the EHRs that were all server based, they didn't automatically transfer things, simple things like demographics, diagnoses, medications from one note to the next note, even though it was the same patient. So the structured EHR data, that when people talk about that, you're talking about what moves over from one encounter to the next. Now, when we talk about different ways that we can streamline, obviously that makes your life easier, because now, obviously, the patient's diagnoses are not really going to change if you're doing a follow up on them. Their medications, the dosages may change, or we may reduce one medication after they've gone through, for example, like a Z-Pack or something like that, or something more acute, and then move to a more stable situation. Or we may take medications off entirely, but at least we have at a glance what that patient is on. It really helps out when you have multiple providers that are working in the same space. So, your hospitals, your EHRs, your post-op clinics, where you have, your pre-op, your ortho, and then your post-op, and that can be done by three different providers. So this way everybody's on the same page. This allows for the quality and maintain high without having to increase more time. Now, when we look at what's the next step of that, back during the meaningful use days, there was a concern about what's called canned medicine, which is ironic because now, with the high tech and everything else and the omnibus rule, they've kind of gone away with it. They haven't gotten rid of it, but they ignore it pretty much entirely now. The federal government ignores it pretty much entirely now, where basically they're wanting practices to make sure that they cover everything. So on the administrative side, I want to make my life easier for the providers, especially if I'm asking them to do something new. I'm sure everybody remembers the ICD-10 code change from ICD-9 and that mess. So one of the ways that we always did that was we would create templates on the EHRs, for the various types of encounters, from evals to medication management follow-ups in our cases, to counseling sessions. And we would go through, and every EHR is like this, where you can either create your templates on the fly, or you can work with the programmers to work on the templates and have them set up in different ways, depending on the way the provider likes to practice medicine. Maybe you have a very verbose provider. All right, just give them a word box and let them type, you know, or some of them incorporate text to speech or speech to text rather. So, maybe you have a dragon setup. So your provider can just dictate and it just moves along intelligently so they can review it and sign it. Some of them set up for boxes. So you can just, all right, let me click this box. It puts that phrase, click, puts that phrase, click, puts that phrase, click, puts that phrase, and we move on to the next piece instead of having to make the provider type. That really helps out with providers of a certain age that are not very tech savvy
Mm.
and grumble every time they have to boot the computer or the EHR automatically logs them out for compliance purposes. So these are kinds of things that we can do to really make sure that we're hitting all those metrics that we need to hit. So for example, meaningful use, one of the major metrics was prescriptions electronically, sending those electronically. That was an easy one. Now for macro and MIPS, we have hey, are we talking about smoking cessation? Hey, are we talking about, their weight because of diabetes? Hey, are we talking to them about, for example, we do a lot of class twos. Are we talking to them about the possibility of becoming a habit forming drug because it's a class two? Are we informing them what that means? So on and so forth, the pros and cons of the medications. So there's a lot of legalese that we can put into the template without having the provider make up the words on the fly for every patient. And a lot of practices, I mean, if we think about how much time it takes for them to do a note, if they were to write it all out, this is where you have the provider has a stack of folders on their desk from 2 weeks ago. That's not
Right.
realistic. I don't remember what I had for dinner yesterday. You think this provider is going to remember a 15-minute from 2 weeks ago? No one is that good. And then make it consistently 2 weeks just like that. That's not good, and then it's not a great quality of life. I remember my uncle came up, he just retired last year, GI doc. Man, that man would have a stack on his desk and he would be seeing patients 8 to 5. From 5 to 9, if he wasn't on call, he was doing notes because he didn't have time to do it during the day. So
That's
now the
brutal.
federal government is like, no, we have to decrease the burnout of these providers. And as administrators, we want to decrease the burnout because they're happier. And when they're happier, the morale in the office improves. There aren't as
Everybody
many
wins.
interpersonal issues,
Mm.
there aren't as many blowups where then you have to navigate the minefield because even though everyone is valuable to an organization, who's more valuable, the person that creates revenue for the practice or the person that just is support staff? Like it's, and I say just support staff because they don't bring revenue in, providers do.
Right.
That doesn't mean they're not important. They could be a billing person. They could be our front desk person. They could be an RN that's doing a bunch of things in between, before and after, that are value added, that are that can be part of even other streamlines of revenue. But our main source of revenue in healthcare is provider to patient. Whether it's a PA, an MP, an MD, a DO, a
Essentially, it's
DC, a PT.
compartmentalizing your practice.
Yeah, yeah.
Doctors
So
charge of seeing the patients, and support staff is, you got a
yeah,
scheduler,
yeah.
you got a biller,
So I mean,
etc.
you
Compartmentalize it.
we got to look at this stuff and say, hey, okay, what can we do to make it easier? And we're bringing on a new provider to our practice right now, and I literally was like, hey, the first thing we did was, all right, you've gone to HR. Now here's the EHR. Luckily, he has experience with the EHRs, and we're like, just play with the templates. See if these are to your liking, and then just let us know what you want modified. Or if you have a copy of a template encounter from your old practice, bring it over, send it to
Right.
us, and we'll put it in. So there's a lot of EHR functionalities now that I know the big ones, all the big ones have the ability for you to create the template on your own.
I was
Practice
gonna
Fusion,
I was gonna
all
ask
scripts, clinicals. Yeah, go ahead.
Jose, Do they have any AI formats now for these templates, or
So it's a
just curious?
great question. So the AI piece is very interesting. So this is where you start flirting with that line of canned medicine. And though I know that some of the insurance companies are using AI to help ping with pharmacy benefits,
Mhm.
and there are court cases in regards to that as well. So AI is a garbage in, garbage out kind of data system, right? So for now, they're a little bit too crude to be used effectively on a day-to-day basis because as much as medicine is a science, there's a bit of an art form to it as well. Because especially when you hit the specialties, because this
Sure.
person is all of a sudden it's not just somebody like yourself or myself that's coming in for a Z pack twice a year, or hey, I
Yeah, it's
got the
a case
flu
by
because
case
my
basis, right?
yeah. So I mean, when you're dealing with a specialist, like an oncology, ENT, even GI, there are, especially mental health, pain management. When you're having to deal with medications from multiple different specialties and how they affect the system, and mitigating the side effects,
Mhm.
in some cases we'll have patients where they have more medications that deal with the side effects of two drugs that are actually doing the work to solving the problem that the patient has than anything else. But all of a sudden that one patient now has seven meds, but they came to me for depression. What am I supposed to do with this? This is an extremely complex patient. The AI may be able to tell me, hey, this drug doesn't play well with that drug, which is what a lot of pharmacy systems and a lot of e-prescribing software do now.
Makes
They
sense.
do help in that way. But in the complete decision-making AI format, I still think that we're aggressively 5 years down the road from seeing anybody try it because the liability would be huge.
Now it'd be interesting to see where it goes.
Oh,
Obviously, AR,
I mean,
AI. I've even read things about there's some sort of AI related apps. I think they're still in testing phase, but they're going to be more or less linked to EMR systems that you sort of put in the patient note, and it sort of does the billing, or it does the billing cycle for you. It puts in the code and stuff for you, all that stuff. And I've read some
yes.
things on it.
Yeah,
It's
so I know
very
that
interesting stuff.
Kaiser, I believe it was Kaiser or was it Molina? Last year they published a study that they did on quality of care
Mhm.
and accuracy from AI to providers. And it was interesting because the AI was a little bit more accurate, but it was still something that was jarring because there is an aspect to medicine that requires some empathy, right? Like,
Of course.
it's not just them going to fix the plumbing in my house or fix I may have an oil leak in my car. There's an aspect to this that, hey, we've got you. You've got someone to talk to. You have a team here that is the office, and that makes things a little bit easier, especially when you're dealing with more complex and serious factors. If you're going to the ER and your family member just got into a car accident, do I really want to talk to C3PO?
No.
I mean, as
You
little
wa-
EQs
need
I've seen some providers, I still want to be able to talk to somebody.
no.
I still want, sometimes the biggest job that ER nurse is doing is calming down the family, which then calms down the patient.
No,
If
absolutely.
I mean,
Absolutely.
what are you going to tell a parent that their kid is there because of a soccer injury? Like a big old gash in their forehead, or a bicycle accident gone wrong. Yeah, they were riding their bike and they ran into the freaking curb, and what happens? They had a helmet on, so their head didn't get cracked open, but they broke their arm. What
Mm,
are you going to tell that parent? You got to tell that parent, hey, you got to be calm. You can't go in there freaking out because you're going to freak the kid out more than the kid's already freaked out with all the sounds and all the noises and all the people and all the this and all the that. So, I mean, a robot's not going to get that. And AI is not going to get that. And even if you program something like that in, there's still going to be a place for people. It's just going to be transformed,
you
if
need
you
the
will.
human aspect in those situations, 100%.
Yeah,
No
we're
doubt,
humans.
no
You're
doubt.
gonna need that aspect. Now, there's a lot of cool things that people are working on, in the prosthetic angle with 3D machining, but we're going down the AI tangents here. And I mean, I've even seen it where they're using lasers and AI for they talked about it for surgeries to make the incisions smaller.
Hmm,
Because anybody in the ortho field or experience with ortho will tell you the reason why the patient has as many pain meds as they do after an ortho surgery is because those guys are auto mechanics on the human body. The tools they use, you would not know that they're coming out of
it's
an
wild.
auto garage or a
I've seen
surgery
some videos.
room. Like the way that they hammer in some of
ACL
these knee
tears are interesting
replacements and
too. All that.
yeah, man.
Uh,
It's just like, God, you're giving me meds because of the trauma, not because of the actual procedure. So, um, but no, so I mean, you can go to the next one. When we go to um when we go to where we're going and where the EHRs are even kind of helping and starting to help is especially on the billing side, like you mentioned, where they're saying, hey, if you're going to be using this diagnosis, have you checked this, this, and this? So that way it can
right,
help support the diagnosis, which then you can turn around because most of us are still in a fee for service environment. We can then turn it around into, hey, all right, well, then we need to ask for this procedure, or we need to ask for this lab, or we can do this service in the office. So it's something to where you can really, again, maximize your output based on your input.
right,
Now, traditionally, the process would be you have a consultant, you have a biller, and they review a group of notes and say, hey, you're missing out on this opportunity, this opportunity, this opportunity. And by the way, you're doing this illegally, and this is a big no no. I don't know who told you to do it. You better stop right away. So now you're catching these more on the fly. Some of the systems can do it, some of the billing companies can do it. And the Practice Fusion is not doing, they're not coordinating yet the code to the diagnosis because some things are a little bit trickier, right? So if I'm doing a basic outpatient procedure using an E&M code from let's just use the follow-ups, right? Let's just use a 99213, a medium complexity office visit, right? A 15-20 minute visit if it's a Medicare patient. There are so many diagnoses that could go with something like that. Hey, I came in for a flu shot. Hey, I came in because I slept wrong and my neck is weird. Hey, I'm following up because of an ankle injury. I'm following up on my medication management for my heart. I'm following up because of a depression medication management visit. So like there's some codes that are too broad still, and in order to get more specific. So if we use A diagnosis, you can use B, C, and D CPT codes. It would require a lot more, how can I put this? Paperwork and mapping, which programmers don't know medicine and people who are in medicine don't know programming. So it's very different. It's very, very different when you're talking to both of them. And when you have both of them in the same room, a person who can interpret wants to blow their brains out because it's just they're talking past each other. They don't know what the other person is going through to do what one side is asking. So it's gonna take it's gonna take quite a bit of time. Um, One of the things that I have been seeing is that some of them will go and say, hey, if you have a certain diagnosis, it may be able to piggyback with other diagnoses that could be a little bit easier to work with. Something along the lines of, hey, if I've got diabetes, I may have edema somewhere because I have swelling, or hey, if I'm an amputee, there may be some cardiovascular issues going on. If I've got diabetic neuropathy, then I may be having pain somewhere. So there's different things that you can do and that you can piggyback, but that's on the administrative side. So, for example, on our EHR, I went through the trouble of just blocking all of the code subsets that have nothing to do with our practice. So, even because of the fact that we are mental health, but we do some primary care because, some patients that come see specialists don't have primary cares. We blocked oncology codes.
Yeah, makes
There is
sense.
no reason why we need to be using oncology
Saves
codes.
you some time too, obviously, when you're
It
going in there.
well, it saves time, but it also reduces error. So
Yes.
let's say
Yep.
that, one of my people are having like an dyslexic moment and they put a 2 where the 1 is supposed to be. All of a sudden, they're like, "Hey, what's going on? That's not working." It'll pop up faster which codes they're actually looking for, both on the diagnosis side plus the CPT side. So those are things that administrators can do that can help move things along and speed up the post post patient encounter process. So,
Limits your liability as well of
oh
that
yeah,
happening.
absolutely. I mean,
So
you can. I mean,
I,
go ahead.
I was gonna say, so these these EMRs, these EHRs, they don't come like out of the box accustomed to your practice. You have to, obviously go in there, get yourself acquainted, and
So,
uh,
so there are some that
remove the
are.
fat, if any. You know what I mean?
Yeah, yeah, yeah. So there are some that are more generalized, your larger guys, your eClinicals, your practice fusions, your all scripts, your Athenas. There's one more big guy that I always forget. Anyways, those are more generalized. But then you have some that are specialized to the practice, which then there's pros and cons to that too, because you pigeonhole yourself on one side, but on the other side, it's catered more to the experience you have general in your practice. So there's one that it's called Emma,
Mhm.
and it's for why am I blanking on it? It's for crap. It's
I know there's some EMRs, catered
yes,
towards
it's
chiropractor, like I think
yeah, yeah,
Chiro
yeah, yeah.
Touch
So
is
Emma,
one.
yeah, Emma is for the skin doctors. I don't know why I'm forgetting
Gotcha,
their freaking
gotcha.
specialty right now. But so that one is catered more towards that. So, there's different things that they do on their end to make it more user friendly so that user interface is far more geared towards that style of practitioner.
Right.
However, if that same practitioner decided to bring in a subspecialty that makes sense. So let's say that I'm in an area that, yeah, I do a lot of primary care, but I want to bring in a rheumatologist because I'm interested in building an infusion center on the other half of my building that I invested in 20 years ago that the tenant just left for whatever reason, right? Now, all of a sudden, I have to make the decision. Do I make this square peg fit in this round hole, or do I go to a new EHR entirely to support that new subspecialty? Or do I give them a new EHR entirely and now I'm paying for two EHRs? If I'm one practice and I'm wanting to bring in a multi specialty kind of setup, the generalized way is the way to go. It just
Sure.
requires the administrator to be a little bit more on top of things because then they got to cater to two different specialties,
So in
if
the
that makes any
no,
sense.
that makes sense. So in the telehealth, mental health game, is there any specific EHR for that, or is Practice Fusion sort of?
We haven't used it. I mean, we just used Practice Fusion because it was
But that's
honestly
a
it was cheap.
generalized EMR that you sort of put
Absolutely. It
together.
is extremely generalized. Practice Fusion actually started out as a free EHR before Allscripts bought it. And so it
I
was
want
used by
to.
a
I've
lot of.
used it before. It's funny. When I was doing the weight loss stuff a million years ago,
Yeah,
that's the EHR system that we use, and I think at the time it was a free, it was a free version.
yeah, it was free because they gave you ads. There
Yeah.
were ads on the banners.
Yep.
And it was always the same, pharma ads as always. But um with that one, if you remember, and it's still doing that now, they actually have community templates where then you can look up the specialty and you have different specialists
Oh,
that have
that's nice.
created their own template that you can rip off completely
Right.
and then just be like, hey, doc, how do you like this? You like it? Perfect. Here you go. And so you don't have to recreate the wheel. You let somebody else who's
Yeah.
already done that
It's
do
already
that.
there.
Or
It's already
you,
there
or
for you.
that gives you the building blocks, because everything's based off of a SOAP note, subjective, objective, assessment, and plan. Oh, hey, I don't like this in the objective. I think this is more of a subjective measure. All right, well, that's easy. Copy, move, delete. Done.
Right.
Like on to the next thing, right? So we want to make things easy. We want to make things, I hate to say it like this, but as cookie cutter as possible,
Yeah.
because that's what the insurances are doing to audit what we're doing on the in the trenches. It's what the federal government's looking at when they audit our notes at the CMS level. So, what we've got to do is we just got to figure out, again, we got to figure out what the rules are so that way we don't get in trouble. It's just like going to Monopoly to your friend's house. If you don't know the house rules, you will lose. And probably, depending on how competitive you are, maybe lose a friendship, right? So, we want to make sure that we know what those rules are. And this is where, having a consultant or a biller that knows what they're doing, that has experience, can help you with that. A lot of times the EHRs have their own billing departments that you can use as well if you want to do an all in, a one stop shop kind of setup. I have mixed reviews on that kind of a setup. I
I
have
was gonna
mixed
say, it
feelings
sounds
on it.
like you don't want to sell yourself short, because if you do end up adding subspecialties to your practice, then it almost seems like it's better to go with a
Well,
general
again, though,
vendor.
it can be a situation where if a practice has been around since the Obama era, the meaningful use PPACA era, they have and the studies support this. They have moved EHRs 3 times
Hmm.
because a lot of the EHR companies that were around back then, going through all of the rigmarole, are gone or they've been bought up because they couldn't keep up with all the changes that only the big guys could keep up with. And what the big guys have been doing is they've just been adding more value added components to become an entire ecosystem. They added billing, they added a clearinghouse, they added looking at you, change, looking at you, e-clinicals, where so I mean they added e-prescribing used to be a completely separate piece
Right.
from the entire EHR. So
I
when
remember.
meaningful
Yeah,
use
I
first
remember
came,
the in the weight loss. It was a that wasn't all tracked in Practice Fusion.
yeah,
That
it
was
was no, it was two
PDRX or some.
completely separate pieces.
Yeah. Yeah.
So it's something to where you had to get used to what you're looking at doing. So if I'm starting a new practice today, I need to have a clear vision of what we're doing, not just now, but 5, 10 years from now. If I'm in an established practice, you need to have the conversation of, do we actually want to have this horrible conversation of switching EHRs? It is a nightmare to switch an EHR.
That seems like that's a last resort option.
I've seen divorces that go smoother. I'm
Well, you
not lying to
mentioned
you.
you mentioned as well the idea of maybe using two EMRs as an option as well. I
I
don't know which one
It
would
is
be.
an option, but it's not usually
It's
feasible
not.
because
I feel like
it
that's very costly to just.
oh, it's extremely costly. The only way I would ever do something like that is if I had an umbrella corporation and each specialty practice was its own company, which I may have to do anyways, depending on how my insurance contracts are set up.
Sure.
So it's funny how with the advent of the ACOs and with the advent of MACRA and MIPS and the things that these legislators want healthcare to be able to do, in one side of their mouth, they're telling us Stark exists. You better watch out for the Stark law, the kickback rule. But then on the other side, they're like, no, we want you to be able to talk to each other and coordinate data and coordinate care. Well, what the hell? You're telling me this is illegal on one side, punishable
The
by
double-edged
jail
sword.
and yeah, but yeah. It's like, what do you want me to do here? So until there's a little bit more clearance and some more court cases coming through, which I'm waiting to see how some of those go. There are some running through the systems. Usually they're coming from the insurance side, though, sadly, because the insurances are getting into the practice game.
Right.
If I mean, I just read an article literally over the weekend. 3 out of 4 providers are now part of a larger system. So the idea of a provider that is standalone, has his own practice, completely independent, it's dying off. And it makes sense because we have all of these different rules and costs to where the profit margin doesn't exist the way it did 20 years ago. So you're having to consolidate into a group of some kind so that way you can pass some of these costs that you have, your compliance costs, your some of your HR costs, your payroll costs, your I mean, shoot, your credit processing costs.
Oh yeah.
Like anything I can pass along over 4 or 5 practices is gonna make my life easier. I can't support as a 2 provider office. I may not be able to support an HR department. But if I have 5 different companies that are 2 provider offices, now with all of our budgets combined, we can support having an HR department. You know what I mean? So
Yeah, it makes sense.
all of this stuff for the next 10, 15 years, you're going to see a lot more consolidation. And you're probably going to see groups of providers come together to see how they can leverage different pieces of this, even so much so when they start putting some of this AI stuff in there. I'll be interested in seeing if some providers that want to leverage that for maybe their more simple cases, their 212s or 213s in office. I just need my med, move on, or I just need a pack of ice, move on, like low level stuff. I can see that happening. You're still going to need somebody to sign off on it, which is interesting. And you're still going to need somebody with a DEA license if they're going to prescribe a medication. So it's going to be interesting how some of this streamlines through. But when it comes to the workflows, we've got to understand our workflow.
Of
What
course.
data can we put in from the jump street from when that patient first comes into existence into our ecosystem? What can we put in right away that can then map all the way through? There are certain things that don't change. Your address, your every year and now the insurance changes, but it used to be that it didn't change for 3 or 4 years. So you could just put it in once and not have to worry about it. Well, now we got to go and ask the
You
patient
got to
every time we
confirm it
bloody
every
see them.
visit.
Hey,
Yeah.
has your address changed? Hey, has your insurance changed? Hey, has your this changed? Has any of your
And then they
medications
got to
changed?
sign off on it each and every time too.
Well, and the sad part is we have to sound like a robot asking that question every time on the front end now because on the back end we're not getting paid.
Right.
Because even though we asked this of the patient, they're not.
And
Maybe they moved. Maybe
right.
they moved, or maybe they got sent a new insurance card. Medicare. This happens every year with Medicare now. Now you got to
Oh
start
yeah.
bothering the Medicare patients in November. Like, hey, look, man, I need that Medicare card. You got it. I know you got it in between November and December. Just go ahead, bring it, take a picture of it,
Bring it
send it
on
to
in.
all your providers. I tell our staff every November, every December, when we reach out to the Medicare patients, we just tell them, look, just take a picture of it and email it to all of your providers and just be done with it because you're gonna have to bring it in for us to be able to bill for your services. And us being able to automate this data entry on the front end and then during the encounter and then on the back end, hopefully as we continue to grow and more things get automated, hopefully that will go and allow for providers to get paid faster so then less things end up in patient responsibility. Realistically, and in my experience, what's going to end up happening, what's going to increasingly happen is that more things are going to be denied because of either lack of pre-authorization, because that's a fun one,
Mm,
or they're going to go and say that that's not covered under it's not supported clinically, like, hey, you don't this isn't supported, so we're not going to approve this medication, or we're not going to approve this service. And that happens a lot. And there's actually a court case out in California in regards to pharmacy benefit managers. I want to say for Humana, don't quote me on it. It may be Cigna, where the pharmacy benefit managers have been running through AI, and because of garbage in, garbage out, the PBMs, as they're called, are not approving medications to patients.
Interesting.
So when that happens, what do you do? Well,
So
then you
they're
got to
relying
appeal.
strictly on an AI. They don't have anybody sort of
Well, that's
review.
what
You always got to
the
have like,
plaintiffs.
I was gonna
Go
say
ahead.
like the billing AI stuff I'm hearing about. Like it's not gonna do it all for the person, but it's gonna put all the codes in based off the encounter, and then you're still gonna want somebody to review it. You know,
Logic
before
dictates
submitting.
you're correct.
That's
But I mean, I know that in the PBM case, what the plaintiffs are alleging, because this isn't all the way litigated yet,
right.
which it may be a topic that we want to get into if everybody's kind of interested on that. We can dive into that court case specifically. But basically, what they're alleging is that they were using either AI or an automated program of some sort, or an algorithm, to automatically deny certain medications because of quality, but in reality, it's because of cost. Because these pharmacy benefit management companies and departments are based on, hey, if I can give you a generic that does one thing and it does it for 20 different things, I'm going to approve that medication and not something more specific. In mental health, we see it a lot with aripiprazole. It's used for a lot of different conditions,
Mhm.
but the problem is that it can be not as effective for certain patients because it's covers everything. If it works with anxiety, it works with depression, works with this, it works with that. I mean, but does it? Does it work better than something that's specifically designed for that one condition? I mean,
That's a good point. That's
I'll let the
a
clinicians argue that one.
good
I
point.
yeah. So I mean, there's a lot of different things with this, but as long as you can defend what you're doing, which is where us on the administrative side setting up the templates so that way the providers can hit those bullet points more effectively, more quickly, more easily, it makes everybody's life easier because the claim goes through faster, the patient gets the care that they're looking for faster, the provider doesn't get frustrated for having to add addendums to the notes, the biller isn't frustrated because it's denied and now we got to do this paperwork or that paperwork. So as we find tips and tricks to make things easier, don't worry, the insurances and federal government are going to adjust as well. So we just have to kind of like stay on top of it, and
Roll with the
it's
punches.
gonna, yeah, it's gonna be constant research,
Mhm.
on the administrative side. Like, all right, what can we do here? All right, what can we do there? All right, what can we do here? I know Practice Fusion, for example, I'm constantly calling them. Hey, can we do this? Hey, what's the timeline on that? Hey, what's this? Hey, how about that? Um, hey, is this on their radar? Hey, is this something that's never going to happen? Why? Because I want to find solutions to problems, or either that, or I like to look ahead and say, all right, I know that this problem's coming down the pipe. Let's see, can we get to it before it's actually a problem? Let me problem solve before this blows up in my face.
Do you have somebody
Um,
dedicated from Practice Fusion? Just curious.
Yeah, well, so
When you ask
I
those
have
questions,
I don't I don't want to put
do you pay
her
for that? Do you pay for an additional for a for a rep or a
so
account manager?
EHRs, just like you at Epi Compliance, EHR companies also have a point person for different things, right?
Gotcha.
Sometimes they'll put it to different departments. Sometimes they'll put it to just, hey, overall, this is your account person. So, what I normally like to do is create a very close relationship with that person. And as you onboard and then you transition to somebody else, I always keep that person that I really like, that really worked well with me, in the back pocket so that I can
Of
get
course.
help that may not necessarily be official, but officially needed. You know, like,
It's
um,
continuity right there.
well, it's not just continuity, but I like to keep in touch with people that
Yeah,
work
of
well with
course.
me, and that's
Yeah.
not always the
Yeah, yeah.
case. You know, I'll admit I'm a very difficult person to work with because I ask a lot of questions because of what we do on the consulting side. So I look at things in a different way than perhaps a normal administrator or provider that is also an owner would. So I'll ask the question of what about this, this, and this, and I'll be like, all right, well, we're looking at incorporating this opportunity. Can we do this, this, and this? One thing that we're looking at doing, and I'm more than happy to talk about it, is we're looking at doing ketamine from home. And the idea would be that the patient is taking the ketamine from home, and we're supervising them. But we're supervising them in a Zoom chat. So I'm talking to video conferencing tools. I'm talking to Practice Fusion, like, hey, how do we set this up so that I have one person that can view, just to put a number out there, 4 people, but they can't see each other. I don't want them seeing each other, but I want to be able to view them at the same time in the easiest way possible for my employee to make sure that they're not having a bad experience. You know, we joke and we call it trip sitting.
Sure.
So
Trips.
um I mean, it's not something that we have to do, but it's something that we want to do because we want to make sure that the patients have the best experience possible.
You
So
don't have to
it's
you don't have to
something.
hook them up on a I don't know, one of those Apple Watches or anything to
Well,
monitor
so
vitals for them.
we don't have to do any kind of the remote monitoring or anything like that for the gummies that we're looking to
Gotcha.
do.
Gotcha.
But what we are looking at doing is, like I said, a Zoom, and so that way that's just up while they, listen to music and zone out, and our trip sitter's just there. So if they start freaking out or they start having a bad trip, they can jump on and say, "Hey, calm down. What are you feeling? What are you doing? We got basic protocols. Hey, do A, B, C, and D. Hey, how bad is it? Do you want me to call 911 and EMS? And then we would call 911 for that patient. And so it's very much just to make sure that they're not having a bad experience. Um, I don't want a Matthew Perry type situation. May he rest in peace. So I mean,
Very
it's
very interesting stuff. You said that's a newer treatment or a newer.
Well, so the ketamine's been around for a
It's been
while.
around,
We can
yes, but this
Yeah,
doing
yeah,
it
yeah.
from
So
the
it's been
home
around in
and the
different forms,
mental
but now
telehealth
you can do it
standpoint.
with gummies.
Gotcha.
So,
Interesting.
um, yes, I mean, but when it comes to clinical decision making, we got to just make sure that we've got to make it easy for everybody. Easy for everybody means that it's got to be hard for somebody. And that's usually you're either in these kinds of cases, either your administrator or your biller.
Sure. Sure.
I would say honestly, if I'm looking at the problem and looking at the providers, I'm going to work backwards. What does the biller need to build this? All right. Then we go and say, hey, provider, here's the tool for if you find that it's clinically necessary, then use this, 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 and this. If it is not clinically necessary, do not do it. I am not officially coaching you to do this because of this.
Right.
You know what I mean? Like we want to make sure those caveats are there, but again, it's because we're trying to follow through with one set of guidelines, but the other set of guidelines says that we can't do that. So we're trying to navigate a very tight trench and not hit any rocks. If you have questions, concerns, please feel free, reach out to myself, Eric. You know, billers, coders, they have experience in a lot of this stuff as well. Maybe not your specific EHR. I'll tell you, I don't know all of the EHRs, but most of them work on the same. The
I
UI may be
was gonna
different, but
say,
the basics are all the same. It's just like a car. BMW may be different than a Nissan, but are they really that different? They're all internal combustion engines. They have 4 wheels, you know,
I was gonna
T
say that
ignition.
when you found Practice Fusion, what was your main, or just I guess in general, what's the main selling point you're looking for in EHR,
Well, I'm different than
especially
a lot of.
if you're a new physician in practice looking to you know get set up with one.
So one thing for me was the modularity.
Hmm.
I wanted to be able to set up the templates the way that my providers wanted. Because a provider that has to change the way that they practice medicine is not one that's happy for 6 to 12 months. Even though the way that the EHR may be set up is the most appropriate way, as long as they're hitting the notes, I really don't care. Like 1 plus 2 is 3, just as 2 plus 1 is 3. Do I care that the one is first in that equation? Absolutely not. I just care that it's there because
Right.
blank plus 2 does not equal 3. So for me, modularity was important.
Yeah.
Cost was important. And then at the time, we were looking only for secure video conferencing plus the EHR. So those were the big things that we were
And that
looking
just
for.
comes the secure teleconferencing. That's just the caveat of just being in the telehealth side of
Yeah,
things.
we
Gotcha.
telehealth was always from the
Subset.
beginning going to be part of our business and a heavy part of our business. So we planned for that in that kind of scenario. COVID just made it easier.
That's for sure.
Yeah, yeah,
Well,
that was
now
a fun
Jose, I
conversation.
appreciate all this insight, and um, I hope you guys found some value in today's presentation. And we are going to have a short question Q&A here in just a moment. I just wanted to take the time for those of you that don't know, and we mentioned this in, I would say, almost every webinar, but
Yeah,
according to
if we
OSHA regulations, when it comes down to OSHA training for you, your staff, it is required that any new hire take that training within 10 days. So um, just want to throw this out there. We have a site called epicourses.com where we do offer a free OSHA course. Highly recommend taking advantage of that, especially if you have any new staff members as of recent or in the future. Please take advantage. It is a federal requirement of OSHA to have that training done within 10 days. So, as I mentioned, we do offer that a free course on our EpiCourses site. You can take a lecture, you take a test, you get a downloadable certificate at the end. Easy as that. Again, Jose had mentioned earlier, Jose is in the consulting side of things on healthcare. He's done everything from startups, obviously running medical practices, etc., conducting security risk assessments. If you guys have any questions, concerns, please feel free to reach out to him. Um, he is absolutely here to help. And if you guys are interested in learning more about Epi compliance and or our compliance solutions, please feel free to reach out to me. Would be glad to connect over a call, over email, whatever's easiest for you. We're here to help you guys out. Other than that, Jose, I don't know if you want anything else to add, but we'll open up for a quick Q&A here.
No, not at all. Other than we're always looking at topics that are popping up in the news or
Yes.
that we're having conversations with clients. So if there's something that you guys are interested in and you want us to do a deeper dive on it, we're more than happy to do so. If it's as long as it's healthcare related, that's really what our bread and butter is. If it's compliance related, even better. But honestly, I mean, I get a few phone calls about different things all the time, so
No,
I'm always doing research.
absolutely good point. If you guys have any topics or anything that's going on in today's healthcare industry, let us know. We'll gladly talk about it. I think next week's webinar, Jose, we're going to be revisiting the Change Healthcare cyber attack and sort of going through the lawsuits that are currently going down. So,
Yeah. By then we should find out if the court in Tennessee is allowing them to consolidate
mhm,
the 120 cases they already have.
just wow.
This thing they haven't even fixed the problem completely and they already got 120 court cases.
I was going to say it's not fixed from what I've read.
They're not completely done yet.
And
They're not completely done yet. And I mean, we'll go more into it, but I
sure,
mean,
sure.
the UHG, United Health Group, already got in trouble with the federal government and lawmakers because they didn't show up to Congress.
Oh
Their
man.
subsidiaries did, but United Health Group was
No.
like, nope, not going, not sending anybody.
United Health. Wow.
No, we
Wow.
own it, but we're not gonna own it. I'm not touching it.
Isn't that wild? That's what was it that we read in that initial article? This has affected was it a third or two-thirds of the population? I'm trying to,
1/3 of the
still
American population was
insane.
affected and that was and I'm sure that number's gonna go up just because of the number that internally UHG is preparing to lose this quarter
United Health.
between the loans, the payouts,
I'm not going.
the I mean, shoot.
That's wild.
You kidding me?
Yeah.
You know what that's like? That's literally like, hey, your principal called your kid got into a fight at school.
Yeah.
What do you want me to do? That's my kid. Yeah, all right. Yeah, I claim him, but I'm not there with him day to day.
Right. Man.
And it doesn't help that the federal government and the FTC were not necessarily happy about United Health Group buying Change 2 years ago because they were
Mhm.
concerned about monopoly issues. So
Here we
this is
are.
going to make things very, very interesting.
No, for sure. I can't wait to talk more on that. That's going to be an ongoing, I'd say, webinar topic for quite some
Oh,
time here.
yeah, we're gonna be
We're
able to
following
farm
the
that,
chain right
milk
now.
that cow for quite some time.
Absolutely. But if you guys have any questions, concerns, whether it's today's presentation or just in general, please feel free to chime in chat. We'll take this next couple minutes to answer your questions. And in the meantime, if you guys could be so kind, give us a follow on our social medias. These webinars are recorded and we do post them on our YouTube channel. So if you do subscribe, you'll see the updates for that. And yeah, any questions? I know somebody's got at least one.
I mean, a lot of this stuff is we've been doing it for a time. We just didn't know why for a lot of
Sure.
people.
Or anybody
So
that has a topic that they'd like us to discuss, feel free.
yep.
Chime in.
Oh, I don't
Jose,
know
I
if you
like
heard
that.
that in that car.
Oh, we got an emote from Bendel.
Yeah.
It's a wave.
What
We
do we
got a
got?
wave emote. I'm waving back, Bendel. Well, at the very least, I hope you guys found some value from today's presentation. And like I said, we do these every Tuesday, same time, 1:35 p.m. to 1:55 p.m. Yes, I do realize we've gone a little over, but hey, um, like I said, we try to instill some value, some insight, and perhaps there, obviously EMRs have been around, but perhaps there was something that you might have heard that, you know, might have piqued your interest, or maybe perhaps you didn't know that was going on. So, but all right, Jose, I guess we'll close down shop for today. And again, everybody, I appreciate your time, and hope to see you guys next week. As I mentioned, everybody's going to receive some correspondence for next week's webinar registration. And again, look forward to seeing you guys attendance there. Jose, appreciate your
Yep,
time as well, and can't wait
definitely.
to get an update on the Change Healthcare cyber attack.
Definitely, man.
Going to be a good one. All righty, guys. You take care. Have a good rest of your day, and we'll see you next week.
Take it easy.